Okay, we are live. Okay, good day, everyone. We are on our 32nd program on our series of learning basic arthroscopy. We have a very interesting talk today that is primary repair of the anterior cruciate ligament for femoral side avulsions. We have very big masterminds from the whole of Latin America. I would like to share our speakers and our panelists today. Okay, I welcome Professor Alex Weisman. Dr. Alex Weisman is staff of Knee and Sports Medicine Department, Clinica Alemana, and Chief Staff of Knee Surgery, Hospital Padre Hurtado. He is Associate Professor of Orthopedic Surgery at Universidad del Desarrollo, Treasurer of the Chilean Orthopedic Surgery Society, Orthopedic Surgeon of Club Deportivo Cobresal. Sorry if my pronunciation is not up to the mark. And he is also honorary member of the AOSSM and editor of the Orthopedic Journal of Sports Medicine, and also editorial board member at RCHOT. It's a pleasure inviting you, Dr. Professor Alex Weisman. Thank you for accepting our invitation. We also have Dr. Professor David Figueroa, Publicity. He is Chief of Knee Department, Clinica Alemana. He is also Professor, Faculty of Medicine, Universidad de Desarrollo. He is past president of the SLRD, the South American Arthroscopy Society. He is executive committee member of ISACOS, and he is also editorial board member of Journal of ISACOS and editor-in-chief for RCHOT Journal. Thank you very much, Professor David Figueroa, for accepting to share your knowledge with us. We also have Dr. Manuel Mosquera, also called Dr. Mosco. He is orthopedic surgeon and knee and shoulder surgeon. He is currently president of SLRD, that is South American Arthroscopy Society, and second vice president of ACART Society. He is one of the board of directors of ISACOS, is member of ESCA and ESCOT. Thank you very much, all. I'm happy to say that all of them are my friends and good teachers. And thank you for accepting to share your knowledge today. I kindly invite Dr. Alex Weisman to proceed on with his program, and subsequently we will have Dr. David Figueroa sharing his knowledge and experience with the repair of the femoral avulsion of ACL. Dr. Manuel Mosquera will be kind enough to ask questions and moderate the session. Over to Dr. Alex Weisman.
Okay. Thank you, Sasi. Let me see. Can you see my presentation there?
Yes.
Excellent, excellent. Well, first of all, good morning for us. It's very early here in Chile. And I want to deeply thank Sasi for your invitation. It's a pleasure to be sharing with some friends this subject, which is very interesting, about ACL repair. This is my disclosure. And the objectives of this talk are to clarify the concept of ACL repair, to show the principles and indications for this procedure, to show the ACL repair techniques, the most popular at least, and to revise the available data and outcomes. We all know that ACL tears are very common injuries, and most of these athletes need surgery to recover their knee stability. The first ACL repair techniques were described well over 100 years ago, and the open ACL repair was the gold standard up to the 70s and 80s. Unfortunately, they showed a high failure rate of 53% at 5 years post-op. So, and then with the newborn of the ACL reconstruction and the 80s and 90s, these techniques were left in the past. So why try to revive them today? Do we really need this? This is a beautiful work from HSS about ACL reconstruction, not repair, ACL reconstruction. And they showed that they have a return to sports of almost 90%, with an overall satisfaction of 85.4%, and 98.1% of their patients would have surgery again with a rate tear of less than 5% at 2 years. So this is a very successful surgery. Are we going to be able to beat these numbers with the ACL repair? Well, the ACL reconstructions are cool. That's not mistaken, but they're not perfect. There is donor side morbidity. There are tunnel-related complications. There is a chance of proprioception and range of motion deficit, and the muscle atrophy, which has a long recovery and rehabilitation to recover. And of course, having tunnels make it more difficult to revise. Moreover, there is current availability of MRI, which they didn't have on the 70s. There are bioactive scaffolds, which may aid on the healing of the ACL. Specialized devices for getting a stronger repair, and minimally invasive techniques. So as a matter of fact, if you see this graph in the bottom right, the studies around about ACL repair that have been published in the last years, you can see how in the 5 last years, there has been a boom of studies, and it's still growing. So we're going to see more information about ACL repair in the next years. And the concept of ACL repair is important not to mix it up with what is ACL augmentation with a graft. When we talk about ACL repair, we're talking about direct suture or reinsertion of the ACL stump. And it can and should be augmented with a biological, maybe scaffold or substance, and a structural augmentation with an internal brace or a dynamic intraligamentary stabilizer, like you can see in the bottom right. In order to better understand the ACL repair, we need to classify the tears. The first person to classify these tears was Sherman in 1991, and he recognized that the proximal avulsions had better outcomes than distal avulsions. And there is a newer classification from 2017, which is seen in magnetic resonance imaging. And this classification by Di Felice divided the tears in 5 types. Type 1, only 16% of the tear pattern was type 1, which is the proximal femoral avulsion. Type 2, 27% of the cases had this type of tear, which is a proximal tear between 75 and 90% of the distance from distal to proximal in the ligament length. Type 3, which is a mid-substance tear, and you can see it in 52% of the cases. Type 4, a distal tear, seen only in 1% of the cases. And type 5, it's a distal avulsion, which is seen in 3% of the patients. What is interesting is that you can see that type 1 tears, which are the tears that can be repaired, that should be repaired, not the other ones, are seen in this graph in the green color. And you can see that the 2 columns in the right are patients older than 35 years old. And they have you can see this type of tear in up to 23% of people older than 35 years old, sorry. But in the 2 columns to the left, you can see that the green line is small. Only 8% of the patients less than 35 years old have this type 1 injury. So less than 10% of the patients younger than 35 years old could be amenable to an ACL repair. So the indications for this surgery is in proximal avulsion or tears, type 1 tears, acute injuries less than 21 days, because in animal studies have shown that a longer period is associated with poorer results. You need enough length of the ACL stump to reach the lateral wall, adequate tissue quality in order to be able to repair it, of course. There have been better results in the skeletally immature because of a better biological potential of healing. And in isolated ACL injuries, there are no studies in multi-ligament injuries. So in this type of injuries, this technique should not be used. In the surgical principles of ACL repair, the first thing is to evaluate and protect the ACL remnant. Then you suture the ACL stump with non-absorbable sutures by means of a labral scorpion or other type of suture passer. You give 2-3 passes through each bundle of the ACL, the anteromedial and posterolateral bundles, and then you need strong fixation to the lateral wall by using anchors, sweep locks, cortical buttons, or any type of pullout. It's important to enhance the local healing response by doing a microfracture of the footprint, or shaving of the lateral wall of the notch, or by using biologic adjuvants. But it's important to notice that PRP by itself has not proven to be a good adjuvant to improve healing in this type of repairs. It's important to achieve anatomic femoral fixation in order to recover functional of the knee, to protect the repair by using an internal and/or an external brace. And there have been described 4 main techniques, which we're going to see, but unfortunately, with just a few cases per technique, and with a short follow-up of less than 5 years. So the first one that we're going to show is the dynamic intraligamentary stabilization technique that uses a dynamic spring screw implant in the tibia. The first thing is to repair the ligament the usual way with a pull-out technique, and then you put this device in the tibia, and you use a non-absorbable tape that is fixed with a cortical button in the femur, the lateral femur, just like you can see in the video right now. And this tape, non-absorbable tape, is fixated to the tibial implant, which has a spring that allows for 8 millimeters of motion and protects the ACL repair through all the range of motion. So this is it's called the ligamis technique, and it's what you're seeing right now in the video. What are the outcomes of this technique? Well, unfortunately, it's been described a high failure rate of 15% at 3 years, especially in high-level athletes, which are more prone to failure. So it's not recommended to use it in high-level athletes. The revision rate goes up to 20% at 5 years. And with good functional results, just like you see in the graphic, but with a rate of implant removal up to 50% of the cases because of a symptomatic device on the tibia. So it has some pitfalls. The BEAR technique, the breach enhanced ACL repair, uses a protein scaffold from a bovine tissue plus 10 mL of blood, and this scaffold is fixated in the repair site by using femoral and tibial cortical buttons. The only cohort of patients has been described by Martha Murray. It's with 10 patients, they are waiting for the FDA approval to start using this device. And she compared these 10 patients with 10 patients with ACL reconstruction with hamstring. And with 2 years follow-up, she showed similar functional outcomes between the BEAR technique and the reconstruction, with less loss of hamstring strength in the BEAR group and with no failures in the both groups. You can see this picture of an MRI of a patient with the BEAR technique 24 months after surgery, and you can see that it doesn't look really like a normal ACL, but it has continuity of the fibers. This other technique, the ACL repair with a Tyro Plus internal brace, is my personal favorite. As you see here, we use the scorpion, the pass suture passer. You pass a suture, a non-absorbable suture, in each of the bundles. Then you pass the sutures through this button, the cortical button, and a fiber tape through the adjustable loop. We fix it to the lateral wall of the femur, just like here. And then we drill a small hole, a small tunnel, just to pass what would be the internal brace, the fiber tape, through the tibia. So you can see how it's looking there. You fix the internal brace in the tibia with a sweep lock or an anchor or a button, and then you tie up the sutures of the repair in the cortical button in the femur. And you can, this is performed at 90 degrees of flexion, and then you can adjust the adjustable loop and give some more tension to the fiber tape with the knee in full extension as needed. The results of this technique have been described by McKay in 68 patients, but only with 1 year follow-up, with good functional outcomes and a rate of reintervention of 6% with only one failure, which was seen at 18 weeks post-operatively in an athlete with he had an injury, athletic injury, and one arthrofibrosis, one meniscal tear, and one patellar osteochondral lesion that needed surgery. So very good results. And this is the last technique, the anchor ACL primary repair plus internal brace. And you can see that you use the same scorpion suture passer, and you do a bundle type of knot in each of the bundles. Then you fix each of the bundles to an anchor, or in this case, Di Felice was using a sweep lock for each of the bundles in the footprint of each bundle. Here he's fixating the AM bundle. And then we're going to see a separate fixation for the PL bundle with another sweep lock with the knee in 90 degrees. And finally, an augmentation with an internal brace by using a suture tape, fiber tape, just like we saw in the before video. And remember that this tape has to be tensed in extension. So the outcomes of this technique have been published by Di Felice, a cohort of 56 patients, 27, all of them were ACL repairs, 27 of them had internal brace and 29 without an internal brace with 3 years follow-up with excellent functional results in most of the patients, but a failure rate that was almost double in the group without an internal brace. So here I want to emphasize the importance of using an internal brace when you do an ACL repair. So regarding rehabilitation, there are different protocols depending on each author. The papers tend to be more aggressive when they use the dynamic intraligamentary stabilization system, but most of the authors use a post-operative brace for about 6 to 12 weeks, allowing for range of motion up to 90 degrees on the first 4 weeks, partial weight bearing beginning at 2 weeks, and running, they allow for running at 10 to 12 weeks, and the return to sports begins around 6 months after surgery. So the risk factors for a poor outcome with ACL repair are patients less than 24 years of age, a preparative TechNurse score of more than 5, very active patients, high-level athletes, so it doesn't seem like a good idea to use this type of technique in a high-level athlete, especially if he's very young. Mid-substance tears, when there's disruption of the synovial shift, there are poorer outcomes. Open surgery as opposed to arthroscopic surgery, and a post-op side-to-side knee laxity of more than 2 millimeters after surgery. So this is one of the two systematic reviews of this ACL repair from last year, and the outcomes show in 2,400 patients show pretty good functional outcomes, around 80 to 100% points of Leeson scores, with a patient satisfaction of 90%, with a return to sports or work at 14 weeks, an ACL survivorship of minimum 60%, but up to 100%, but with a re-rupture rate of 23%, a revision rate of 12.9%, less than 5 years, non-revision reoperations of 18.2%, and unfortunately in the MRI analysis, there is still not much experience. What we have been able to see is that there is high intensity of even more than 12 months after surgery. So it's still not a very good tool to follow up of the patients. So as a summary, I think that there is a role for ACL repair, but in a very specific population that has proximal tears or avulsions of the ACL. The tears have to be acute, less than 21 days. And specifically in the skeletal immature patients, they have a better biological healing. It is mandatory to use internal brace and biological augmentation in order to achieve a good, successful outcome. Theoretically, the ACL repair has better propulsion, less morbidity, less condyle damage, and a faster recovery than ACL reconstruction. But all the studies up to date show a survivorship of the ACL reconstruction, which is superior to ACL repair at short to intermediate term. The ACL repair results in a greater rate of non-revision reoperation, and up to this date, there is still not enough evidence to support its routine indication. So as a final thought, I believe that in the future, we might start thinking about ACL tears just like we do today with meniscal tears. Just like we say today, save the meniscus, maybe in a couple more years, we're gonna start talking about saving the ACL. Thank you very much.
Thank you very much, Dr. Vaisman. You can stop your screen share. Yeah, wonderful. Thank you, Arman. That was a very interesting program. There are a lot of questions, though. I think that is the purpose of the talk. We will have the questions after Dr. David Figueroa shares his experience with ACL repair. Over to Dr. Figueroa.
Okay, can you see my screen?
Yes, sir.
Okay, well, first of all, I would like to thank the Indian Society of Sport and Arthroscopy and, of course, my friend Sasi for the kind invitation as a panelist in this interesting topic. It's a great honor to be here again, sharing with some experiences with the colleagues from India. And I would like to start presenting a case of a 29-year-old man. This is a parachute and paragliding instructor who falls with a torsional mechanism on his right knee when landing, leaving him with pain and an effusion in his right knee. This is it is a real picture of this patient. That's a little bit crazy, huh? Next day, the patient attended the emergency room and where he was evaluated by the orthopedic surgeon on duty. And the physical examination highlights on his right knee some effusion, some lateral pain. The range of motion was perfect, but decreased by pain only. He had also an anterior-posterior instability with an anterior drawer test 2+, and the pivot shift test was negative. The X-ray taken in the emergency room were normal, and is discharged with indication of ice, rest, anti-inflammatory drugs, and an external brace just for avoiding pain, and take an MRI on the next week. These are two complementary X-rays that were taken the same day in the emergency room that shows only a moderate swelling of the joint. Well, the following week, the patient attended my office with the MRI, and as you can see here, there are some direct signs of ACL tears, including focal and diffuse high signal intensity within the substance of the ACL on T2 weight image, as well as the lack of continuity of the ACL with a detachment in his femoral insertion. Here are some other sequences of MRI. We can see with more detailed changes of the normal pattern of the ACL fibers. And at that time, I would like to stop 1 minute and ask Alex, with those images, history, and physical examination in this patient, would you consider to perform an ACL repair, or would you go directly to an ACL reconstruction?
Well, I think that what we see in the MRI is a type 1 injury. So this is a very good case that could be amenable to an ACL repair. Our typical approach, of course, to this type of patients is a reconstruction. But I think that the sport that he practices, makes him a good candidate to a repair. Besides, he doesn't have a pivot shift. He's 29 years old, so So I think this is a very good case to go for an ACL repair, to consider, at least consider it.
And Moscow, what are your thoughts regarding this case?
Yes, I always that I see this image, I going prepared to do a ACL repair. No matter if the patient do a high sport level, in that cases I add the internal brace, but I don't have any doubt to do the ACL repair.
Yeah, you both are moving to perform an ACL repair. I agree with that. But what would be the best moment to do it for you? We are 1 week after the surgery now.
Well, in my experience, it's not too easy. It's not easy to repair in acute phases because it's not easy to do the repair for each bundle. So in my experience, I prefer to pass 3 weeks or 4 weeks, and then I do the repair. I need to the stump have a coverage with the synovium, and for me, it's easier to handle and do the repair.
Yeah. And how about you, Alex? What is the best moment for doing it?
I think that at least as reported in the literature, time is important in order to achieve the best results. So I would try to put him into the OR the following week at the most. So 2 or at the most 3 weeks after the lesion.
Yeah. Well, as you can guess, I perform an ACL repair in this case, and I did it in the second week of the lesion, so I didn't wait more time. And I will show you some details of the surgery and the technique. Of course, the standard anterolateral and anteromedial portals are created and arthroscopic inspection of the knee is performed. This is the view of the first view of the ACL. A passport cannula is very important and have to be placed in the anteromedial portal to facilitate the suture management and prevent interposing the soft tissues. That's very important for taking the sutures out, etc. In this case, also there was a partial tear of the lateral menisci in close to the root, posterior root, and was treated with a partial resection only, and a grade 4 chondral lesion of the lateral condyle that was treated with an osteochondral autograft transfer system procedure at the same time. So I had a lot of work with this patient. Here we can see the torn ACL completely. I mean, it's a grade 1, as Alex said, with a proximal rupture. In my experience, that cases that have a rupture in the mid substance or distal, or where the ACL remnant is retracted of a poor quality, I perform a standard ACL reconstruction. I escape from doing an ACL repair. And that has to be talked in details with the patient before the surgery. I also do a small, slightly opening notchplasty, as you can see in that video. And then a standard tibial ACL guide is placed at 55 or 60 degrees at the center of the ACL footprint. A skin incision is made above the pes anserinus. In this case, I use a 4.5 millimeters tibial tunnel that drill, just passing through the tibial cortex of the ACL footprint. That's allowed me to prepare the track through the ACL for the high strength tape, the internal brace. The drill is manually advanced, maybe not drill exactly, through the distal part of the center of the ACL stump. And a fiber stick is passed and pull out through the anteromedial portal also. And here, the lasso end of a looped wire is placed over the end of a suture passer. In this case, I like to use the Scorpio device and load it on the suture passer. With the fast pass corpus device, we now bring the fiber of ACL and pass 2 sutures in the mid substance and around and through both bundles, and pull these wires also out of the anteromedial portal as a loop. Some guys advocate to do 2 separate sutures here, one for the anteromedial bundle, another one for the posterolateral bundle. In the next step, as Alex said in his speech, I do microfracture in the femoral footprint to refresh this area, trying to get out the stem cell of the bone. And this is a very important step in order to improve the possibilities for biologic repair. And then I use again the retrodrill system, but in this case, in an outside-in technique to create a femoral tunnel, in this case, 4.5 millimeters tunnel diameter, reaching from outside in the femoral footprint and then passing a fiber stick in this place. Thus, in the future, will allows me to have a tunnel for passing the sutures of the bundles. This is the cortical button that I use. This is from Arthrex. In one hand, you have the fiber tape, and in the other hand, and the other side, you can put the sutures that are going to pass in our sutures through the through the both bundles. And it's very important to have patience to create this internal brace construct by looping a fiber tape suture through the loop of a double-loaded tie rope implant. For that, we have to remove the large fiber wire passing suture from the eyelet next to the loop, and using the flipping suture first as the passing suture, and place the fiber and tiger repair sutures from the ACL stump through the eyelets next to the tie rope. So we have both sides, one load with the fiber tape, as you can see here in the scheme, and the other one loaded with the sutures that take the ACL to the stump. This is how we can see in the arthroscopy all the sutures that are passing with the cortical button. The loop wires tied with the 2 tension strand on the femoral button with the appropriate tension on the ACL. And of course, at the end, the remnants of the loop wire tension strand and the high strength tape are cut and removed. Just let me show 1 more minute. This sometimes it's not easy to get the tunnel with this button in this suture, and you can be confused, or you can traction an inadequate suture first. So we have to be very careful and very patient at that time. This is how it's look in the scheme. Finally, we will have a cortical button with the suture of the both bundles and traction that to the stump. And on the other side, you have the fiber tape. Finally, tension is applied over the fiber tape in almost full extension and fix distally. I like to fix it with a sweep lock. In this case, I use metallic sweep lock. At that moment, we are tensioning in both sides, one for approximating the attachment of the ACL to the stump, and distally for having a good tension of the internal brace. This is the final view of the repair. You can see almost anatomically with good tension. This is the other view from the other portal. And those are the final X-rays the day after the surgery in this patient. This is the MRI at the control at 6 months after the study, showing a good pattern of maturation of ACL in the anatomic position. Also a good integration of the OATs that was performed in the lateral condyle. More projection and views of the ACL repair and the magnetic resonance. This is an oblique view. More details, and this is the last MRI. This is the patient 6 months after the surgery. The physical examination showed better function with complete range of motion, no swelling, no pain, no stability. This is a video. You have to be gentle to do that, that test. Full extension, full flexion, instability in all planes. So the patient is very happy. And these pictures were sent by the patient just 1 week ago when I asked him about the sport that he was practicing currently. This is 1.5 years after the surgery. He invited me to jump in parachute with him, and of course I refused. That was the patient that I want to share with you, and now we can go to some questions. Thank you.
Excellent.
Thank you very much, Dr. David. That was a very interesting presentation, and it's very interesting to see the outcomes. And obviously, a professional athlete is never going to listen to the doctor's advice, and it was interesting to see the images after the surgery. Also, I kindly request Dr. Mosquera to take over to ask a couple of questions.
Yes.
And share your experience also.
Yes, Dr. Vaisman said that evidence show that it's better to do in acute phase. But in my experience, my long experience is based in chronic cases. So what do you think about to do this procedure, for instance, in a patient like the patient David showed us, but the patient had 1 year injury? You see the same image, you got a good remnant, the patient got a mild instability. What do you do in that case? You do reconstruction or you do the repair?
Interesting question. You know that I see type 1 ACL tears as sort of like repairable meniscal tears. So when you have a chronic meniscal tear, each time we have been we have more courage, you know, we're more confident to repair chronic tears. Remember that some years ago, if the tear was older than 3 months, we would not repair and we would do a meniscectomy. So, but after time, you know, it has taken more than 10 years to show us that this type of meniscal tears, you can repair them as long as you follow some technical pitfalls, you know, especially making you know, a rasping of the meniscus or a pinning of the meniscus in order to achieve good healing. So I think that in the ACL repair setting, we're almost going to that side. The evidence still does not support it's not that it doesn't support, but it supports a better outcome when on fresh tears than on chronic tears. But maybe in the future we're gonna learn something different. In my case today, if a patient with 1 year old tear comes to my office, I wouldn't offer an ACL repair. I would go for a reconstruction. But I think that in the future, you know, maybe it's going to be different. There's no enough evidence to support that today. Maybe in your experience, you have good experience with that?
It's a good example that you explain. Is compare meniscal repair, chronic meniscal repair versus ACL chronic repair. For me, the most important is the quality of the tissue. For instance, I have a broken handle, a meniscal broken handle. For instance, 1 year injury. But if the handle, the meniscal broken handle, reduce easy, and the tissue is a good quality, I do always repair, no matter if the injury has more than 1 year. That is the same thing that I think when I do a ACL chronic rupture. If the stomach is in a good quality, I mean, it's Sherman 1, just Sherman 1. And you see the vessels, the collagen, and you can reinsert, I do it. And for me, you can read a paper from Dr. Di Felice that he did a procedure with a patient with 10 years injury. In many of my cases, I did it 2 years after the trauma. So for me, the better scenario is if you have a good quality of the remnant. Because my toe is no one graft, the best graft never is better than the original tissue.
Moscow, I would like to add that in the current experience and in the literature, I mean, in most of cases, the patient that have more than 3 months after the lesion are a kind of contraindication for surgery. That's what the literature said. Mm-hmm. And I would like to see your results and, of course, what's happening in the future, because I like the comparison that we are doing with meniscal tear. It's true that years ago, I mean 10 years ago, nobody think that in a meniscal tear more than 1 year we are able to repair that meniscal tear. And now in young patients with a good quality tissue, we are performing meniscal repair. Nobody had thought, I mean, 5 years ago, more close, 5 years ago, that we were able to repair a radial complete tear of the
horizontal cleavage.
And now we are doing that, yes. Because the results are good if the tissue is good. So I agree with you. We have to explore, we have to expand our boundaries in terms of probably repair more cases than we are doing today. But we have to look at the results.
Yeah.
Let me precise this, Sasi.
Yes.
Many of the proximal ACL ruptures heal in other side of the right side. I mean, many of them heal in different part of the lateral wall or in the PCL synovium. So they keep tissue. So in that cases, I do the repair, no matter the time.
Yep. So I would like to make it short. So you are one of the key opinion leaders. So you you can very well bring your outcomes. So it is going to make a lot of change in how this thing is going to be seen in future. So we are looking forward to your outcomes, and you made a very important point both with respect to the meniscus and also with the ACL. By saying that the meniscus, the bucket handle, is easily reducible, so you implied that it's sort of flexible, it's not rigid, and so the quality is also possibly good. Same way, it is also logical that if possibly the ACL was already adherent to some other structure, so there is some amount of turgor tension that is happening to the ACL, so the quality of the ACL is also possibly being maintained, so you should be able to repair it. That's a very good point.
Yes.
We are very hopeful and looking forward to your results. I have a couple of questions. Okay, I recently had a patient whom I had taken up for ACL reconstruction because the MRI suggested that the patient, MRI was of finding that ACL reconstruction was needed. It was like a type 2 tear. That means a proximal tear. So, but it was not like a femoral avulsion. But when I was inside on table, it looked more like a femoral avulsion. So my hands were itching to do a femoral side repair, but unfortunately, I had not explained the patient that the possibility of a femoral side repair, the rehabilitation is going to be different, the outcomes are going to be different. So if you are taking a patient for ACL reconstruction and you find the patient is an ideal case for a ACL repair, what do you suggest?
Well, good question. To avoid that situation, I check very well the MRI, and for me it's important the Lachman and the drawer, because when you got this kind of rupture, I mean in chronic setting, the patient doesn't have Lachman grade 3 or a private grade 2 or 3. Many of them have 1 or 2 Lachman or drawer test 1 or 2. So I put all this information together and I explain all with the patient what I want to do. I mean, I want to do a repair, and I explain that. But sometimes when I go in the scope and I see a small remnant in diameter, I add a biological augmentation. I mean, a short graft. I mean, gracilis, no more than 7 or 8 millimeters, and I do an augmentation. In 100 of my patients were posterolateral augmentation, because ACL remnant always keep the AM tibial insertion, always. So I explained the patient before the surgery, Sasi. That's the thing.
Okay,
but this is a surprise to me. For instance, I thought that the remnant is not good, but I found that this is good. I do the 2 procedures: the reconstruction with the small graft, a small hole, and add an repair.
Okay. Dr. Vaisman.
Well, in Chile, I would say that the surgeons are still a bit reluctant to ACL repair. I don't know how it's your experience in India. So here, if you have not explained the patient beforehand, then you have to perform an ACL reconstruction, because if you go for the repair and by any chance it fails, which it is a chance, 20%, 30% possibility, then you're going to be in trouble, okay? But I don't know, I wanted to ask you guys, Dr. Srinivas and Sasi, what is the reality in India regarding ACL repair? Is it very popular technique? Are the surgeons reluctant to doing it, or what do you think about that?
That's Srinivas.
First of all, thank you very much, Dr. Vaisman and Dr. Figueroa, for the excellent speeches. As far as the Indian experience is concerned, I personally myself don't do ACL repairs, and I think that very few surgeons in India do ACL repairs. So possible reasons, maybe one, experience, two, patient affordability could also be a cause. So it's not very popular in India. ACL reconstruction is is done more. Yes, sir.
Dr. David.
Yeah, Ceci.
Yes.
I would say that in the next future, again, coming back to the menisci lesions, when we approach an arthroscopy, we always have the devices, the tool for doing or for performing a meniscal repair in every patient now. That's a reality now. Probably in the next future, in every patient that we are going to perform an ACL reconstruction, we will have to have between our tools those for doing an ACL repair also. Yeah. So that's my thought according to the ACL repair. ACL repair is just one technique. It's not for all patients. It's just for a few patients, but you have to have the tools, the devices for doing almost in every case if you need it.
Okay,
Yes,
so
David.
I'm sorry. Okay, so the devices are usually manageable. So can I extend your statement to a corollary that you should also explain all patients that there is a possibility that an ACL repair could be possible, and if that was possible, then that could be done, and it might be good for you? Because the question is about the consent from the patient. Possibly we will be able to manage with ACL repair with respect to the implant is concerned, but with respect to the consent and outcomes.
Can I say one point about this? As Dr. Vaisman, Dr. Figueroa were saying, they're more in favor of doing an ACL repair during the early stages, say 3 weeks, less than 3 weeks. And as we see in our clinics, most of the cases of ACL reconstruction, we usually wait for more than 3 weeks before we go ahead with an ACL reconstruction, unless we actually diagnose the ACL avulsion in the initial MRIs itself. So is that your preoperative, you have established a diagnosis and then going to the theater, or is it likely that you can find an avulsion in the theater when you are, worked up a patient for an ACL reconstruction? What is your experience, Dr. Vaisman and Dr. Figueroa?
In my case, well, for doing an ACL repair, I prefer to do it in the first 3 weeks. Yeah, for the reason that I explained before. And most of patients that I have done this kind of surgery are very well diagnosed by the MRI. I mean, the MRI is a point here. It's very important to check it. That's contrast with those patients with an ACL reconstruction, where we usually wait 3-4 weeks, but wait in terms of some clinical issues before the surgery. I mean, I wouldn't do a surgery in a patient who bend the knee more than 90 degrees, or those patients that still are with a lot of swelling, pain, or because they are prone to more complication after the surgery. And those patients, I'll wait 4 or 5 weeks, sometime, or 6 weeks and doesn't matter to do an ACL reconstruction at the second month, at the third month after the lesion. So, I mean, it's different that the approach if we are going to do an ACL repair or an ACL reconstruction.
Well, I don't know. I want to add. I don't know if you know that in Chile we have a dual healthcare system. So in the private setting, in the Clínica Alemana, where we work with David, of course, we get the patient in the office with the MRI, with the diagnosis about 1 week after the injury, after he gone to the ER, and so we can plan things between 2-3 weeks easily. Okay, and we have all the resources to make the repair as needed. In the public setting, the patient is going to get in the OR months or maybe years after the injury. So the possibility of a repair is less possible. So I think that the indication of ACL repair also depends a lot on the reality of where you work and the possibility of having the hardware to do it, of having a good MRI image to diagnose a type 1 tear and be prepared to go in the OR, and talking about with the patient before the operation, and to have a good timing.
Are there any special MRI sequences you do for diagnosing the type of tear?
Any what?
Not at all.
Yeah, any
No,
special
it's
MRI?
just we're using both MRI 1.5 Tesla and 3.0 Tesla, and both are very similar and have a good definition of the ACL stump. So it's more dependent on the radiologist, the accuracy of the eye of the radiologist, and that avoid you that. Let's see, that could be a patient for an ACL repair, and your own experience.
I think the position in which they do the MRI, taking good cuts in the ACL to identify the femoral side better, the oblique sagittal, it all matters. It definitely matters on the experience of the radiologist and also the radiology team. I totally agree. Dr. Mosquera, you wanted to say something?
Yes. Keep in mind this: Sherman 1 always heal in no right position, but always heal. So patient with Sherman 1 in chronic setting always have the Redman. The problem is what you have at Sherman 2 or 3, because especially in 3 or 4, the Redman reduce in terms of quantity and quality. Many of them absorb it. So that kind of Redman, you can do it in a chronic setting. I never have done a Sherman 3 or 4 repair. I just have one case in Sherman 2, but the repair was in the PL center because it's shorter than the AM. But I'm very strict with my indications. That is the problem when you see and you review the evidence, because they mix sometimes Sherman 1 or 2 or maybe 3. For instance, DIS is used in case of Sherman 3. And that results are different than when you compare Sherman 1 versus 3. If you review Sherman 1 cases, a repair versus reconstruction, the results are similar. Very similar.
I have a question for the panel. Do you take in consideration the type of sports of the athlete when deciding the repair? Because, for example, the case that David showed with the guy or the parachute, athlete, I think that type of sport is a low risk sport for ACL. He has more risk of calcaneal fracture, tibial plateau fracture, polytrauma before the ACL. But for example, in Chile, we see a lot of soccer players or rugby players. Would you consider an ACL repair in a professional soccer player or a rugby player?
Well, I moved it because when I started this 5 years ago, I was very, very afraid doing just ACL repair. So in all that cases between 2015 to 2018, I add a posterolateral augmentation. But when I became confident with the procedure, I started to do an ACL repair isolation, ACL repair. But I changed in my last year because many of young patients, I mean high level activity patients, think that they were not operated. I mean, they don't feel pain. They recover range of motion as soon as they can. So I had 2 patients, one a rugby woman patient and a soccer, that they start early without my permission, of course. So I changed to add, as David showed us, and you, Alex, to add the internal brace. Because in the cadaveric model, probably there is a gap. If you, for instance, you do a ACL repair using knotless, this is my long experience using that implant, you can get a gap. So in young patient, I always right now add an internal brace. In older patient with that kind of patient that they don't have more activity, I do just repair. So that changing. But right now, if I got a high level patient and the stomach is very good, I, without any doubt, I do ACL repair at adding internal brace.
And does anyone consider doing an anterolateral augmentation or tenodesis with the ACL repair?
Yes, Alex, excellent question. I think the only, right now, the Bertrand Sonnery-Cotet studies, he's showing us that adding the lateral reconstruction, you can reduce the risk of re-rupture. So I think this is a good option to add anterolateral reconstruction in that kind of patient.
You know, I found
I'm not sure. Let me add something. I'm not sure that the anterolateral reconstruction or repair with a tenodesis, I'm not sure that it is a good idea for all patients. I mean, today there is a trend, there is a trend or there is a fashion to perform lateral anterolateral tenodesis in all patients of high demand sports. But I'm not sure. I'm not really sure that that should be the way.
Yeah.
Well, you know, in my revision, I'm sorry, in my revision for this talk, I specifically looked for this question, and I found only one work from Sonnery-Cotet, and it's only the description of the arthroscopic technique. Actually, it's published in the arthroscopic techniques, and it doesn't show the outcomes or a cohort of patients. It's just the description of the technique. But it's very interesting.
Okay, I have a question. This is to Dr. Alex Vaisman. So what are the main purpose of doing a ACL repair instead of a reconstruction? Can we take the primary goal is to achieve early proprioception because the native ACL is repaired?
Yes, I think that Dr. Mosco already showed some of the advantages of a repair. One is the proprioception. The other one is it's a little bit less invasive, so patients have less opioid consumption for painkillers, and they recover functionality a little bit earlier. So the return to sports should be a little bit earlier than with a reconstruction.
Okay. With respect to proprioception, do we still have a good evidence stating that the proprioception after a few months, possibly 6 months after ACL repair, is better than after ACL reconstruction? Do we have evidence yet? Do we have evidence yet whether proprioception is better?
I'm not sure there is evidence regarding that issue, but in terms of recovery of the patient, neuromuscular recovery is faster with ACL repair than the reconstruction. That has a lot of papers. I mean, but regarding just the proprioception, it's not easy to evaluate just proprioception. You just we just evaluate patient in terms of their neuromuscular advances.
One big advantage is there is no donor site morbidity, isn't it? With the repair, if the results are equal, we would like to prefer repair over reconstruction if possible, because there's no donor site morbidity at all.
There are many advantages. It's not just the mobility. You don't need to do holes. We create a disease when we are doing an ACL reconstruction, and if a patient failure, for instance, the patient that David showed us, he's going to have the first reconstruction in the next surgery, not the second.
So what do you think about leaving an internal brace through an open physis in a skeletal immature patient? Do you think that you can just leave it there and nothing happens, or do you think that you have to go back and cut it, after 3 months? What is your opinion about that?
There is a paper. The question is if we can use internal brace in
across the physis.
Okay. For the reason that we cross the physis doing the but it's a small hole that as David showed us. It's 4. I use 4. Sometimes people do with 6. I do just with 4 diameter. So probably the damage of the physis is too slow. So in that kind of patient, I add always an internal break, because that kind of patient doesn't follow the direction of the doctors. No, there is one paper that shows a bad result with young guys, but I think, as you show us, Alex and David, that is a good indication for young people. Do the ACL repair instead of ACL reconstruction, because we see in our office young people less than 30 years ago age that have more than 3 surgeries and they have arthritis. This is a bad situation.
Okay.
Chairman's classification is for both the bundles, isn't it? Can there be a scenario where you have one type of injury in one bundle and another type of injury in another bundle? Say type 2 injury in one bundle and type 3 injury in another bundle. Is it possible? And or if it happens, how would you do a repair of one bundle and augment another bundle?
I've never been in that situation, but it can exist. I agree with you that you can face that situation. In that case, type 1, the bundle with the type 1, of course, I would do a repair. And if the lesion is type 2, also I would do a repair. But if the lesion is type 3, I would consider to do an augmentation with the one bundle reconstruction. Just one bundle.
Okay. But this question is for Dr. David Figueroa. So when you're placing a brace along with a ACL repair, would you still like to leave a laxity for the brace, or like fix the brace in length ACL?
That's a very good question because the internal brace is not good to leave it too tight. We fix it in extension or very close to the extension. You have to remember that internal brace is only a secondary stabilizer. It acts as a safety belt, encourage natural healing of the ligament and protecting during the phase of early mobilization for the patient. So I try to leave it not too tight, avoiding one of the problems of this surgery, that is arthrofibrosis or stiffness knee.
Dr. Figueroa, but is there a difference in how you use the brace in an ACL reconstruction and how you use it in an ACL repair? It's the same.
What, the internal brace?
In the internal brace. My concern is when you have a laxity, because it's a repair and the repair is not a strong thing, wouldn't the laxity still allow the repair to move, or can it get damaged?
I really don't understand your question.
Okay. When you have a laxity in a case of repair, won't the laxity allow the repair to stretch out?
Yeah.
Won't it damage the repair? Because in ACL reconstruction, it's a different scenario. The reconstruction is very strong, but in repair, we are not very sure about the hold and the stump or the remnant. And can it pull out?
Well, one of the important things that we have to perform during repair is to go with the stump and inflection and avoiding that laxity that you said, because it's one of the complications of that repair is that the stump is not completely goes to the bone, and there is a space between the bone and the stump. That avoid a good integration of the stump to the bone, and probably one of the problems is that the laxity is going to persist. And on the other hand, in those cases, you are based your stability only in the internal brace. So I mean, the main idea is to be sure that your stump goes directly to the bone stump. Otherwise, don't finish the surgery until you are sure that you have a good position of your stump.
Yeah, David, in other words, Sasi,
yes,
you can fix any residual laxity doing ACL repair with the internal brace. So,
yeah, but it's not a good idea.
Yeah, so you always have to put in good tension the stump in the lateral wall, always. If you can do that, you can't get better outcome adding the internal brace. The internal brace function as as a brace, you know, just. So the main objective is to recover the tension of the normal ACL. Many of the ACL repair doing with, no matter if you do with knotless or bottoms, always you can recover the tension. And you, in the most of the time, you recover with more strength. For instance, if you see the Lachman test that the David patient is better than the ACL reconstruction in the first year. In my cases, when I do the Lachman and the drawer, is tightest than the other side, because you add a more tension. Remember that kind of tissue are historic deformation. So after 1 year, they recover the normal tension. But in the first year, if you compare the Lachman, it's different.
Okay, thank you.
Few questions on YouTube, actually. There are a couple of questions on timing of surgery, and I think we have got answers for that. Well, what is the latest time post-injury to do an ACL repair? The other one is, when is the ideal time to perform an ACL repair? Wait for a few weeks or repair in the first 15 days? I think the answer you have already, Dr. Vaisman and Dr. Figueroa have answered for these two questions. And another question was, will the ACL repair be successful in a skeletally mature? I think what they mean is skeletally immature patients.
Alex?
If the ACL repair would be successful in the skeletally immature?
Immature,
Yes.
yeah.
Yes, I mean, that's the biologically the best group to operate. The problem is that we know that younger, patients have a higher rate of retear, even for an ACL reconstruction. So these are patients which are at risk. I would suggest that if you do a repair in one of these patients, you have to use an internal brace. You have to do a biological augmentation with a microfracture, whatever. And you have to protect them post-operatively with a knee brace. You have to be very cautious because this is a high-risk group for re-rupture. But it's a good group to indicate a repair.
The other question is, what signs of healing of ACL do you seek at MRI in the post-operative period? Do you consider them for the rehabilitation and return to sports?
I mean, the MRI for controlling the ligamentization process is not so good as we expect. I prefer to control under clinical parameters as strength, neuromuscular function, etc., for allowing the patient return to sports instead of the MRI. The MRI, as Alex showed in his presentation, you can find high intensity levels of the ACL structure until 1 year and sometimes more. So, I mean, nowadays we are leaving out the MRI as a system for controlling patients before sending to the sports. I mean, it's good to have it, but you can take decisions just under the MRI.
And if you're performing it in a skeletally immature patient with an internal brace, do you have to remove the internal brace after a period of time? Does it cause any growth disturbances? because it will be put under tension, isn't it?
I don't have information about. I've never read an article about growth disturbance in skeletal minute patients. On the other hand, you know, biomechanically, the internal brace is just working for some weeks, and then the tissues is relaxed, and as Alex asked, if we should take it out, that system in a skeletal minute patient, I would think about that, but I'm not sure.
Because as the child grows, the internal brace will be limiting the growth. It will be a limiting factor, and potentially can cause growth abnormality.
You know, it is a concern, and some of the authors, they pull out the internal brace at 3 months after surgery, but there's no consensus regarding this. There's no much evidence about it.
Can we consider this patient similar to any other skeletally mature patient who needs an ACL reconstruction, and you can make a more horizontal tunnel in order to make the internal brace? That should solve the problem.
You could do an all epiphyseal internal brace. You could do that, but especially in the tibia, you know, the physis is so small that I have some concern about the pull out of that. You know, it's not easy to do a tunnel in the proximal physis in the tibia, and the femur is sort of a little bit easier. So another chance could be to you know, put it out in front through a small tunnel in the physis, but fixing it in the anterior cortex of the tibia below the physis with a sweep lock, for example, or a staple. But you could you could also do a hemiepiphysiodesis of the anterior part of the physis. That would also be a concern.
Yep.
Probably less than going through the physis, but there could still be trouble. So
I think these are very valid concerns, and it should be in the mind. Maybe just a minimally invasive procedure to just cut off the brace anteriorly a few months after you are happy. That should be an option. Okay.
And you would be using a variable loop button, isn't it, for passing the sutures? Could you tell us how you feed the sutures into the loop? You know, when you take the sutures from the end of the stump, how do you feed the sutures into the loop?
David?
Well, today you can find some sutures that comes with the loop. There are some companies that have you just pass the scorpion with the loop, so you don't have to do a special loop. And in my case, in the case that I showed, I did the loop out of the knee, and just push the loop inside the bundles. I just pass a normal suture with the Scorpio, rescue, retrieving the suture out of the middle portal, did the loop, and then push it to inside the knee. But my advice is that if you can use that a special suture that comes with the loop, is easier.
The fiber link.
The fiber link. Fiber link and Tiger link from that comes from Arctic, I know.
Yes.
Okay, Dr. Figueroa, if you're taking the if you're loading the stitch in the scorpion halfway through and passing it through the ACL, you already get a loop, and when you're retrieving, you can retrieve the ends through the loop. Will that solve the problem?
Yes.
Yeah, that will make it simple. You can actually load the loop, lock the loop inside the joint, rather than having to take the loop outside and load it outside the joint.
Yes.
Yeah, Dr. Alex.
Another important pearl is that you have to handle the ACL carefully, be gentle, because you might tear it, you know, trying to past these sutures, you might tear one of the bundles and it's all blown out.
Yeah. As an extension of this discussion, how far away from the end do you want to load the loops?
That's a very good question, because there's no consensus. You have to put the loop in the best quality of the ACL. I mean, the remnant. Some authors have said that you have to use two different loops, one for the anterior bundle, another one for the posterolateral bundle. I prefer to do a complete loop in the base of the ACL and a second one more proximal, but it depends on the quality of the tissue. You have to choose the best place for regarding the quality of the tissues. I mean, that's the answer.
Yeah, I think we have to make a balance between a good quality of tissue and as close to the femoral attachment as possible in order to oppose it and cause a compression on the femoral wall.
Yeah.
Yeah.
We need
That's
a little
right.
bit of control on the stump also, isn't it? So it has to be a little bit nearer.
Yes.
That's
I think
right.
like Dr. Figueroa said, one could be closer to the stump and one could be at the end. So one, you have a good hold on a good quality of tissue. The other could be giving a good pressure on the femoral attachment. I think that's a good compromise that we can.
Some guys have avoided that using that kind of banal suture, you know, as we used to do in tendons. So they start very close to the distal part of the ACL, and they are doing a construct of sutures until the end of the ACL on the top. That's also a good idea when you don't have a very strong tissue in the base.
That construct looks very strong, very promising.
Yes.
Yeah, there is one specific question by Dr. Nicola Zanoli. I think this question was not taken. This is to Dr. Mosquera. What is the failure rate of your chronic repair cases?
This is one of our residents, Nicolas Zanoli.
Yes, and we also have Dr. Alfredo Moreno. He has asked a couple of questions that were taken already.
Okay. Well, let me tell this. For ACL repair, just ACL repair, since 2018, I have done more than 100 cases. And I had 2 failures. It's a short time to show my result, but I had 2 failures. In that 2 failures that I say early, I know you use internal brace, and both patients were high-level patients. So my failure rate is very low, especially in chronic cases. So if I compare my results with the standard reconstruction in terms of stability, there is no difference. The difference is in the re-rate, in the re-rupture. So my percentage of failure in ACL reconstruction is the same that almost all surgeons have. I mean, 5 to 10%. But in ACL repair is less.
Dr. Mosquera.
I mean, I used this technique 5 years ago, starting adding posterolateral augmentation. But I have just 2 years doing just ACL repair. So my early results are very encouraged.
Dr. Mosquera, just one more question. You said, you know, for some of the ACL injuries get attached somewhere else on the lateral wall of the femur. So in these cases, how do you detach the the malattachment, so to say?
Good question. And first of all, you have to take your time. I mean, this is a skill surgery in terms of each step you are very concentrate. You have to get or have in your table your right tools, as David say. That's mean I use hip dissection. Hip is a knife, long knife that the hip surgeon use to detach, labral tissue. Other instrument that I use is a free handle to gently detach the remnant. I use the shaver very low with the face showing up, and detaching down the tissue. So I do the procedure very gently because I need to keep the remnant in good shape. After that, I use, as David showed us, microfracture in all the footprint. Sometimes I do a small hole with the burr. I'm trying to catch the two bundles, AM and PL, especially if you are gonna do a ACL repair, just ACL repair. But if you are gonna add a posterolateral reconstruction, I grab the tissue, as David said, whole tissue, because I'm trying to reproduce the double bundle concept. When I do augmentation, I do posterolateral plus AM repair. If I do ACL repair alone, I catch the two bundle. And I use a separate implant. I mean, two knotless. One of the advantages to use a plate, a mini plate, is that you don't need to use two implants. So it's less expensive. It's because with the mini plate, get the suture that grab the tissue and get the internal brace. And you just use one implant. So it's less expensive. But if you do
Moscow, have you done the ACL repair and multi-ligament lesions?
Yes, very good question. I changed my mind because I do in Bogota, in the small city that I work, many multi-ligament injuries because the people as Indian move by motorcycle. So in multi-ligament surgery, many of the cases that I see keep the remnant. So I use repair for PCL and ACL. Sometimes I add a small graft. And in my last year, I'm adding internal brace, especially for the PCL. And my results are changing. And I read some paper that I'm doing the same, using repair instead of reconstruction and multi-ligament injury. Of course, you have to have a good quality of the tissue. If not, pues, you have to do reconstruction. But if you have to do reconstruction, I right now adding internal brace.
Okay.
Very interesting.
Dr. Mosquera, there are two similar questions. So basically, Dr. Anil Gulia from India and Dr. Chanda, who was previously my professor, they both have asked, if the remnant is healthy, I think you have answered this question already, but I'm just trying to send the message rightly. So if the remnant is healthy, how later can you do the ACL repair? So I guess that you don't exactly look into the duration since the injury. So if the remnant is healthy, you will proceed with an ACL repair irrespective of the duration of injury. Is that right?
Absolutely.
Yeah. Okay. I think the message was sent clearly. So I think it was a wonderful discussion, and we had a lot of questions. Do we have anything else to ask Dr. Alex Weissman, Dr. Mosquera, or Dr. Figueroa? Do you have anything else to convey?
Oh, has been a wonderful time discussing this issue. I mean, we probably we can take 1 more hour discussing.
Yeah, we can take multiple days actually. Yeah, and it's very nice that we have more and more questions than answer. That's a good thing. There are a lot of things to answer, and which we can look into or study with proper research. I mean, prospective study. So I think it was a wonderful session. It was a mind-boggling session with a lot of kindling of the mind that happened. So thank you very much, Dr. Alex Weissman, for your wonderful presentation and review of available evidence so far. Dr. Figueroa for sharing your experience, and the images were good, and the images were crazy, but they were good. Of the athlete who was jumping from skydiving. Okay,
Last slide
and
of
Dr.
Dr.
Mosquera.
Weissman.
No, thank
And
you.
Dr. Mosquera.
I'm delighted to share this experience with you and here at David and Alex. I'm very happy to that happen. I am very agree with David that this topic we are going to hear more than the last year, and probably we are going to have more papers talking about this topic. We are changing because we think that ACL standard reconstruction is a good option, but it's not the best.
Yeah, and we would like to see the results of your adventurous procedures soon. And they are going to change the way it is being understood.
Everything.
Yeah.
A very interesting topic. Thank you very much for the invitation, guys. It was very nice sharing with you and all of the friends. And keep up the good work. Huh?
Yeah, thank you very much. We are going to see you all soon, somewhere in the future.
Thank you, Sasi. Thank you, Professor. Thank you, my friends.
Thank you very much.
Thank you,
Thank you,
guys.
friends.
Have a nice
Please
one.
take care with the COVID.
Yes.
Bye-bye.
See you.